folic acid deficiency or vitamin B12 deficiency, pernicious anemia. So it's very important. Now, so let's go over the assessment part first when somebody has a certain types of anemia. So, what are some of the symptoms that you remember from reading the book? So fatigue is going to be pretty much all across the board that patients are going to be tired. Okay, that's really, really important. So, I'm going to start with that. So there are 24 questions that we're going to go over. I have the questions in my PowerPoint. Once the class finishes, I will upload the PowerPoint. I will relabel it to lecture hematological part 1 question. That means that that's the one that will have the questions in the answer. Okay? So, some patients could have multiple anemias at the same time. They could have iron deficiency anemia, they could have B12 deficiency, and they can also have a folic acid deficiency. Who do you think will have those 3 deficiencies at the same time? Because it's a particular population that will have it. Somebody that drinks too much, right? Malnutrition. It's correct. Important thing you made. Okay. Now, we agree that people that overuse alcohol, right, most likely could have all those 3 deficiencies. So it's really important. Each one is going to be treated in a different way, right? For B12, how do we treat it? Well, that's pernicious anemia. So B12 deficiency, we are going to educate the patient about nutrition is really important because that's the number 1 reason that they have the deficiency. So it could be other reasons. We will talk in a minute. Any questions so far? When I get my email, which is where I have my document. Go ahead.
You said the lower the MCV, the larger the size?
The other way around. Yeah. The smaller the MCV, 80 or below 80, I'm sorry, which would be 70 and below. They're smaller.
He said very much stuff to know the lecture. Yeah.
I can't even see. I don't have glasses. I can't see it. Eyes, I can't put it I love it.
So the people that are coming in, I wasn't late, we had a problem.
Jose, you were late.
Somebody go your desk. Anyway, let's talk about the exam then. 10 of my test questions that we sent to our for today's lecture, and 10 questions for next week Wednesday because your Monday is a holiday. So we will not be here. Well, we will be here. So 10 and 10. All right. The questions on each. Why? So the questions that are going to be on the PowerPoint are very similar to the test questions. Very, very important that for each disorder, you know what the treatment is. So obviously there are going to be multiple treatments, right? But your answer is going to be based on what the question is asking you for, right? If the person is losing fluid, and one of the answer choices is medication, But another answer is transfusion, right? It's going to be about transfusion. So you just have to, or you have to pay a little bit of attention to that. Almost there, almost there. Director of nursing was supposed to come in today. Here we go. So we already talked about that patients can have, or people can have multiple anemia. There are over 100 different types of anemia. The NCLEX only asks you questions on the 24 that we're going to cover, so you do not have to worry about the rest. There are some that are not on the PowerPoint, that are in the chapters. I will not be asking you questions about those types of anemia, because number one, the NCLEX doesn't ask you questions about it, and the probability of seeing a patient that has one of those others would be 50-50. But it's the 25 that we're going to go over today. So, what else can I tell you? For the first type of anemia that we're going to cover, we need to be concerned, number one, the size of the red blood cells, because the lower the red blood cells, the less oxygen the person is going to get. Could it be the same if the cells are too big? Yes. So it doesn't matter if it's too big or too small, the cells, the NCV, once again, if the NCV is below 80, that's micro, small red cells. If it's over 100, it's macro, meaning large cells. And when we get to the disorders that you need to know, I will absolutely tell you what it is. So once again, if it's over 100, the MCV, macro, so large. All right, so what we're going to do, there's now going to be questions on the first chapter. I can't remember the chapter. No. Is it 28? So the questions will be at 29 and 30. Why? Because chapter 28 is talking about labs and the different techniques that we use to diagnose the disorder. So as I go through disorders, I'm going to tell you which ones are the ones, okay? So let's go right to the first one, which is, I think it's line 12. Yeah, it's like 12. Iron deficiency. This is the number one deficiency in the United States and the entire world.
It's 11, correct?
For me, it's 12. Remember, I have questions in between, so that's why. And you don't have the second slide that I have. So I will just put it that mental note. Whenever you see iron deficiency, what's the number that you have?
12.
11. There you go. Now, who are the people that are at risk for iron deficiency anemia?
Pregnant.
Childbearing age or somebody that's pregnant. Earlier, we talked about alcohol use. So the more alcohol somebody uses, the higher the probability to acquire iron deficiency anemia. Yes. Having heavy menses, right? How about having a low socioeconomic status? Because the person may not have money to buy what they require, right? Fruits and vegetables are very expensive. Something that is high in carbs is actually cheaper than fruits and vegetables. Okay? Who else do you think would have a deficiency? Somebody that has a inflammatory disorder, especially throughout the GI tract. People that are over the age of 65. I'm not there yet. Children before the age of 3. Somebody that gives frequent blood donations. I think And then, malabsorption disorders. Right? If somebody has a problem in which they are not absorbing their food, then they most likely are going to develop a deficiency. For some type of anemias, if a patient has chronic diarrhea, that person also will have several different anemia deficiencies. That's really important to know. Okay? So we talked about pregnancy already. The lactation. What's the next thing? So here's some of the signs and symptoms. Now, I know there's a test question of what I'm going to tell you next for sure. So let's talk about the labs that are high and the labs that are low in iron deficiency anemia. Good thing is that it's only one lab that we're concerned that is high, which is TIBC, total iron binding capacity. You do not need to know the name, you just need the letters. The NCLEX is going to give you the letters and what it means. It has to give it to you in parentheses, okay? Just like when we give you an exam, we put it in the exam. Labs also, there is only about 5-6 labs that you need to know the numbers. Because for the NCLEX, you don't need to. The NCLEX gives you the normal range. And when you work, what happens? You have the lab report. It will tell you what the person's result is, and then it will tell you whether it's high or low. Okay? So don't want you to just concentrate on those numbers except for the ones that I'm telling you. Alright? So, what else do you think is important in terms of labs? So we already defined what the high is. The rest that I'm going to tell you are low. The MCV is going to be below 80. The amount of iron in the body is going to be low. But I will tell you that the main lab to determine whether or not the changes the person has to make in food intake and medication is not the amount of iron in the body. It's actually ferritin, because that is the amount that is stored in the body. So the person has certain amount, the person is using it, and when that starts to get depleted, it has to take it from ferritin. So oftentimes that's why people are asymptomatic, because they have something stored in the background. Yeah. Yes. Yeah. So the most important lab for iron deficiency anemia will be ferritin. All right? Because it's the one, it's the storage. How much the person has put aside for the winter.
The storage of iron?
Mm-hmm.
Okay.
Correct. All right?
And this is tested, you said, after they've made their dietary changes and stuff like that?
Well, it has to be tested before. We do the assessment. We think the person has certain type of anemia. We're going to test it for you a whole bunch, right? Because remember what I said. Person could have IDA, which is iron deficiency anemia, can have B12 and folic acid. Most likely that person, depending on the symptoms, is going to be tested for 3, right? It actually may be tested for thalassemia too, but when we get to thalassemia, we'll go over that. So it all depends, right? That's why when we go into a provider's office, sometimes they have to do multiple tests to get to whatever issue somebody has. Because it's not clear. A lot of the issues are the same, okay? So, what other things you think we need to measure? Red blood cells. Sometimes we measure platelet count. That may also be important. H&H, which is hemoglobin N. Good. Excellent. So, we already started talking about how we treat it. We're going to educate the person, because if we don't educate the person about nutrition, the person is going to go back to eating the same kind of food, and it doesn't matter then how much medication they get. So we have to educate the person about proper nutrition, we will talk about that. And then we're gonna put the person in one of these three medications, okay? You don't have to memorize all three medications, all you need to know, that is first what we're gonna use. You have to educate the person of two things. Number one, the stool is gonna change color. It's usually dark. However, if your patient is already eating blueberries, then you may have to tell them that the diet is their stool is gonna be darker, no dark. Okay? So you're gonna have to find out what the person is eating over here. Because somebody could have a deficiency of iron, but they may be eating other blueberries or other food or medications that already change their stool color. So it's really, really important. And you also have to educate the person that this particular medication, actually two more things. To increase absorption, you need two things. Vitamin C, and the medication must be taken on an empty stomach, either 1 hour before a meal, no less than 1 hour before a meal, or 2 hours or more after a meal. However, there are some patients that they take one of those medications and they may start having stomach issues. So then in those patients, we will have to give it to the patient with food. But they prefer to be on an empty stomach. That's why last week, when I was at clinic with my students, I forgot to talk about this. The nurses were giving the patient food medication after breakfast. And I said, that's weird, because I know a couple of the patients were having iron deficiency, so it would be best if they have it before. Okay? So, really, really important. Empty stomach and vitamin C will also increase absorption. Very, very, very important. All right, what else do we have? So your nursing interventions are to educate the patient about the type of food that are high in iron. That includes liver, beans, green leafy veggies, and I'm going to go back. So don't take pictures yet, I still have to do some stuff in here. You're going to take it at the end. Did I forget what I was going to say? Oh, this medication can also cause constipation, so the patient must increase fluid intake and fiber, which the fiber they will be doing it, right, if they increase their food intake of fruits and vegetables. That's what I meant. For some patients, they may need a transfusion of red blood cells. But for those patients, the MCV and the ferritin will have to be very, very low. All right. Here's the first question of the day. Questions? Questions before we move to the actual question? All right, let's do it. So what I would like to do is to eliminate two. I know, that's why I can't look at it. So, okay, let's go down the answer. A, for this particular patient, should they stop? So in the question, there is no indication that the person needs to stop the medication. So, B.
Yeah.
So we're gonna keep that. Okay, how about C?
Yeah.
We like that one, how about D?
No.
Okay, so between B and C, which one is the answer?
C.
So, let's recap. Iron deficiency anemia has a number of side effects, right? Number one, fatigue. Person is gonna be tired. person has to change their diet, if that is what the problem is. If the person is drinking, we're going to talk to the patient about stop, or at least reduce the amount of alcohol. Sometimes patients will do that. They will tell you, I will not stop drinking, but instead of having 5 liters a day, I will go down to 4. And that's a start, right? Medication, we're going to educate the patient about increasing fiber, so that will be by increasing intake of fruits and vegetables. That the stool most likely will change color to a darker color depending on what their diet actually is. What else will be important? Then what are the 2 choices that the person has for iron deficiency anemia in terms of treatment? Supplements, medications, and diet. Very, very important. This must be the IT guy, right? Paula, what's going on?
Recording, let yourself. I can't record it.
I think I didn't even touch it. You go over there and look at that. All right, B12. So there are 2 problems with B12. One is a deficiency, and the other one is pernicious anemia.
I'm sorry, you said the 2 treatments are education,
And medication.
proper.
Yeah, so it will be medication and proper nutrition.
Okay.
That's it? That's it? Okay. B12. Now, signs and symptoms of B12 deficiency are the same signs and symptoms of pernicious anemia. It's how the person acquired one or the other. Okay? Now, okay, so risk factors. Always think for the first 3 anemias that we're going to discuss, low socioeconomic status, not having enough money to purchase what they need. Just like one of the iron deficiency anemia, or GI absorption.
Excuse me,
Yeah,
you said vitamin B12 deficiency anemia is the same as which other?
pernicious anemia.
Pernicious.
Yeah,
We
which
haven't
is
talked
in-
about that one yet, have we?
It's in the next slide.
Okay, great.
Yep. Okay? So, somebody that have a GI surgery, whether it was a band that they put, or they removed part of the GI tract, which is part of the stomach, person can have vitamin B12 deficiency. There are 3 medications that are well known for also causing vitamin B12 deficiency. One is metformin. Then we have the PPIs, which are the proton pump inhibitors. And then we have the histamine blockers, which we have 1 and 2, but this is the brand name, because I figure people will remember this better already. So you have your Benadryl, your Celtec, and then you have the Santec in there. Okay? They are, it doesn't matter if it's a histamine H1 or H2. As long as under that class, there is a probability that the person will develop a B12 deficiency. Vegans, because we found vitamin B12 mostly in animal products. B12, the NCD is macrophytic, over 100. So that means that the cells are going to be large. All right? So all that we just talked about is going to happen in pernicious anemia. The only thing is that in order to diagnose somebody with pernicious anemia, we're still going to run the B12, but we also have to run the intrinsic factor that means that the person has a problem with the intrinsic factor, and that was causing the pernicious anemia. Okay? So, diagnosis for B12, it will be B12, right? And then we'll see the deficiency. For pernicious anemia, we run the intrinsic factor, and if in there, that means that the person has pernicious anemia. Okay? Both present with similar symptoms, and B12 and pernicious anemia present with the same symptoms as folic acid. But when we go to folic acid, which is the next one, I'll tell you which is the one that it does not have. Okay? So, here's the manifestations for both.
Yeah, that's,
Yep, go ahead.
you lost me. When you're talking about, you like overlap switch, or like load, what are you
Yeah.
talking about? So is it,
They both the same. The
They're both
only
the same.
concern that you have to do is that B12 to diagnose is B12 deficiency.
the only thing you're testing was the B12 lab?
No, you have to, you have, for both, you're gonna test for B12 and intrinsic factor. What happens is with B12, only the B12 is going to show deficiency. Pernicious anemia is gonna have a deficiency in B12 and a problem with intrinsic factor. That's the difference. But everything else is exactly the same.
So it's pernicious anemia is the one that the intrinsic factor will show up.
Correct.
Yeah.
Question in the back.
So if I have a B12 deficiency, it's going to make my red blood cells macrocytic, so they'll be larger?
Correct.
Okay, thank you.
You're welcome.
Are all three of these gonna be referenced?
What's the third one?
The folder?
Yes.
Okay. So
I wanted to make sure that we were not going to backwards. That's why I asked.
Is it because they try to compensate for the loss, so they get?
So in every single anemia, the body is overcompensating. Something has to give. So for iron deficiency, because the person has store, that's why the cells are being small. But because for B12 and pernicious anemia, we don't have anything to work with, one that is deficient, that's why they're larger. They're trying to stand to compensate, to attract more. But in the end, it's actually not doing that.
Yeah.
Okay? This is good. Okay, so other symptoms that the person is going to experience with B12 deficiency and pernicious anemia is tingling in the extremities, especially the lower extremities. Could it happen in the upper extremities? Yes, but mostly on the lower extremities. And if there is tingling in the lower extremities, most likely the person is going to lose balance when they walk. All right. For both B12 and pernicious anemia, diet. For B12 anemia, we are going to give supplements of B12. Okay? For B12, we're going to give, for B12 deficiency, supplements of B12 vitamins, right? Got it? We're done with that one. Pernicious anemia, the person needs B12, but it's going to have to be an injection. Okay? And that's for life. Once somebody is diagnosed with pernicious anemia, most likely is going to be for life. However, we do have a subset of the population that have pernicious anemia that do not take IM B12. They take a high dosage of B12. Okay? But in terms of the NCLEX and for the exam, pernicious anemia, monthly IM B12 injection. Okay? This is B12 right here. It comes PO, intramuscular, sublingual, and either intranasal. But the ones that you need to be concerned will be PO for B12, pernicious anemia, IM. Okay?
So with B12 anemia, that's because they're not getting it from like
They're not getting from nutritional source, or because of malabsorption.
So with pernicious anemia, why do they need like injections for it? Like what is the?
The route of administration. So think about, right? Something must be wrong here with B12. Pernicious anemia is going into a muscle. So it bypasses, right?
I don't know.
What do you do now?
No, like I'm trying to figure out like why they need an injection
So-
versus getting it.
Because they don't have the intrinsic factor to absorb.
So, think about the stomach. With a pill, the person is going to absorb it, right? An injection, the person doesn't have to absorb it into the blood, it's going to go right into the bloodstream. So that's the difference.
They don't have the ability to
And
Month.
absorb it, they don't have an intrinsic
Anemia is because
factor.
of the intrinsic factor, right?
Correct.
So if the body can't produce that.
The body cannot work it, cannot absorb it.
For like a variety of reasons.
Yeah, it depends, the person may have a disorder in which, it's an autoimmune disorder, so that means it came from family, so there's a different issue. But oftentimes, kids don't have problems with an intrinsic factor, it's actually adults, most adults that have it. Yep. Absolutely. For pernicious anemia, even though it's a monthly, the first month, the person needs an injection once a week for the first 4 weeks, and then after that is once a month. Once again, to teach you what is going to be pretty much in the exam, what's going to be on the NCLEX, but I have to tell you all the things outside that because you're going to clinical, right? And after, you are going to work in a facility, so you need to know that some things, even though we always tell you somebody with pernicious anemia is always an injection, that's not actually 100% accurate to get them. Even though it's a small percent of people that need the injection, that they may not actually need the injection, they can have a high dosage of B12. It will not be because of preference. It has to be because the injection actually is not working for that person as well as the B12 pill. That's the reason. But if somebody goes to a provider and say, oh, I hate the injection, sometimes it causes bruising in the area, I want to take the high dosage of B12, most likely the answer is going to be no, because it's not, most likely it's not going to work out. Okay? So, B12, if it's a deficiency, PO. If it's pernicious, IM. Here's the question. All right. What do you think the A? Are we going to leave it or get rid of it?
It doesn't say.
So polygraph has nothing to do with it. B,
Yes.
so we're gonna leave that for now. C, deficiency, and then D. So what do you think was the answers?
B.
All right. So let's go over. Oh, I forgot I have another question. Because that was vitamin B12. This is, and the other way around, sorry. This is B12. So what do you think about A? Negative. The question is not giving you any indication about a deficiency in it. Good. How about B?
Yes.
Okay, we'll leave that. How about C? Okay. What is the question asking me for? So, if it's only person having low B12, an elevated NCB must be talking about what? B12 deficiency. For pernicious anemia, we need intrinsic factor. So B is actually out of the window immediately. The answer is C. C, disease may not allow the person to absorb nutrients. Okay? You think the questions are working? Maybe you think for a minute? Do you guys want a whole bunch of questions to do at home? All right, I'll have them ready by tomorrow. I'll send you a bunch of questions, but I'm not going to send you the answers. So I'm going to give you a couple of days and then I'll send you the answers. Don't email me asking me for the questions today, because that's not going to happen. Only send me the questions. All right. There's your answer. What time? 6 more minutes on the roll. Got it? All right. Folic acid. This is very important. Same signs and symptoms of B12 and pernicious anemia, except it doesn't have any of the neural symptoms. So it doesn't have confusion. Please don't write this. There is no confusion. There is no tingling in the extremities. All the other signs and symptoms are going to be exactly the same. It's also a macrocytic anemia. The NCB is over 100. What else? Risk factors. A child that was born of a very low weight. What else? Pregnancy. Poor diet. Big alcohol intake.
Chemo.
Huh?
Chemo.
Yes, chemotherapy, radiation, hepatitis, having hepatitis B, C, or D, low socioeconomic status, and one very, very important, overcooking vegetables and fruits. Now remember, people in long-term care facilities, most of their fruits have been cooked and put in a can. Okay? Why will overcooking will cause folic deficiency? Folic acid is what? Water soluble. That's why. But the more you cook it, the more the vitamins are going to be, the folic is going to be removed. Having liver cancer. Excellent. Oh, during the ages of 9 and 19. Why? What happened? Well, it's in general, male and female. Rapid growth, 10 to 14 years old. Having a gastric bypass. And very important, chronic diarrhea. Where do we see chronic diarrhea? What disorders? HIV? Sometimes? IBS, very good. What other disorders? Crohn's, yeah. What an infection that we see in the hospital, the person.
C. diff.
C. diff. Absolutely. Who needs to increase their intake of folic acid? Pregnant women and childbearing age, right? If you're planning, you should immediately be increasing. That means that person needs 400 micrograms of folic acid per day. Pregnancy, 400 micrograms of folic acid per day. Once again, that's during pregnancy. I didn't say anything about having a deficiency. If the person having a deficiency, it's a whole new number. but during pregnancy, the minimum number will be 400 micrograms of folic acid daily. Okay? It's really important.
Is that before and during? When you start it
Yeah.
before?
Yeah, as soon as it starts signing. Right? So we already talked about this Dyson system, so let's talk about what's going on. So let's talk about the treatment about folic acid when there is a deficiency. The person needs between 1 to 5 what? So it's not going to be micrograms, that will be nothing. Milligrams. 1 to 5. If there is a deficiency. 1 to 5. Now, I'm sure that you go to the clinical rotation and you have seen your patients, male patients, taking 400. That's because they did have a deficiency before, they have 1 to 5, the deficiency went back to normal, so now in order for that person not to have a deficiency, they put the person on a 400, okay? But if the person have a deficiency, it's 1 to 5.
So that one.
Correct.
Is that 100, 100, 500?
1 to 5. Ooh.
Daily, but then you said 400.
400 micrograms
Ah,
during
right.
pregnancy.
Yeah, okay.
Deficiency would be 1 to 5. 1 through 5. No zeros. You're gonna kill that person. You're gonna get that person overlooked.
If they
Right?
have
What
a deficiency,
Yeah.
if they have a deficiency, 1 to 5, a supplement, PO supplement of 1 to 5 milligrams a day.
Correct.
Okay, thank you.
You're welcome.
And if they're, what would you say, how would you explain like the maintenance that you were saying? So they still have the deficiency, but now when you.
No, they will not have a deficiency.
So
It's within
yeah, it's
normal.
formulated out.
It's within, okay. Once again, pregnancy, 400 micrograms.
Yeah.
If there is no deficiency, if the person has a deficiency between 1 to 5, right? After that, if we know that that person most likely is going to gain a deficiency, then we'll put that person with a maintenance of about 400 micrograms.
After the 1 to 5.
Correct.
Their labs are different.
Yes.
Okay.
And I only tell you that because you see that in clinical all the time, that your patient is taking, a male patient taking 400. But I want you to come back to me and say, wait a minute, you told us last week this. Yes, because of this. All right? We got it? Folic acid. Our concern is overcooking vegetables. I mean, there's so many things. If somebody's drinking too much, so everything that applies to B12 pretty much applies to folic acid. It's a different lab, right? Once again, somebody could have a deficiency in B12, folic acid, and iron deficiency anemia. And the person could be treated for all three at the same time. Here's your question. Okay, how about with A? Should we get rid of that answer? Good. B. But we're gonna keep B. How about the next one? Okay, and then D? So it's between B and C. We agree C? All right, so let's take a break until 9 o'clock. And then when we come, it's 9 o'clock. All right, so the next disorder is going to be sickle cell anemia. All right, you have, I told you earlier, you have one question on the exam. Yep, one. There's only one disorder that has 2 questions. So, hemolytic anemia are the sickle cell and the thalassemia.
But you're just skipping that one.
That's not yet. Okay?
Sickle cell and what?
Thalassemia, which are the next two. Okay? So, if a group of, so sickle cell is a group of genetic disorders, what does that mean? That it's passed on from the parents to the child, right? So, the problem with sickle cell anemia is that the cells, the red blood cells, change their shape. And because it changes their shape, that means that the red blood cells are going to die faster. If we have somebody that is losing red blood cells, that person is going to have problems with ventilation because of the shape of the red blood cells. That person is going to have pain. Yeah, the pain can be mild, but other times that pain is going to be severe. And we'll get to the medications when we get to that area. So the parents could have sickle cell disorder, or it could have the sickle cell trait. We're going to go over this because it's really important. And by the way, you can take the picture because I already did what I needed to do. So I'll give you a second to do that. So I did, I told something, that's why. We've been waiting for you to say.
I'm gonna go over there, yeah, picture.
So genetic disorder,
Are you gonna explain that chart?
of course.
Okay.
No.
Wait, no, it's just there.
Before you move on, the two symptoms were pain and ventilation.
So, okay, so if the person has sickle cell disease, that means that the person has two copies, one from each parent of the sickle cell gene, okay? So if it's a disorder, that means that the person acquires two from the parent, one from the mother, one from the father. If the person has sickle cell trait, that means what?
They're a carrier?
That the person only has one copy. Okay? So some of the logs that we need. CBC, the depth, the differential. Platelet count. And certainly these patients will have to, if somebody knows that they have sickle cell, they will have to, both of the husband, wife, or whatever, will have to test it, right? They can test the unborn child too. And the person will have the option for having a child or not. That's their business, all right? This is, I don't like this picture for a particular reason. How many families have 4 kids? Thank you. So it will be best if both parents have the sickle cell trait. That means that there is a 25% chance that the child will have sickle cell disorder. It should be at 25% because you could have one child that could have it, not have it, but if you have 4 children, it could be only one child that has it, could be all 4, right? So that's why.
Wait, so it's 25% chance that each child will have.
Okay? If one parent, so it doesn't matter which parent it is, one parent has sickle cell disorder and the other one has sickle cell trait, there is a 50% chance that the child will have sickle cell disorder. Okay? if only one parent has the sickle cell disorder, all of the kids will have the trait, but not disorder. So if only one parent has the sickle cell disorder, then all of the kids will have the sickle cell the trait, which means that the disease is not going to manifest, it's just going to pass it along to somebody else. No disease. If the parent only have the trait, there's a 50% chance that each children will have sickle cell trait.
So to have the disorder, both parents have to have the disorder.
Correct. They have to have something. The reason that this happened, I couldn't tell you. Right? It's genetics. I am now going to ask you a question of you. The NCLEX, the only question that they're concerned is this right here, the first one. In any nursing book, this is what you're going to see, which is actually this right here. All right? If you are working on a unit that specializes in hematological disorders, then yes. Okay? So the only one that you pretty much need to be concerned is that if both both parents have this trait, that means that there's a 25% chance that each child will have sickle cell disorder. Okay? Y'all do the pictures? Well, it's going to be there. Simple. All right. Sickle cell crisis. This has to do with pain. Okay? The outcome of a sickle cell crisis is going to be pain. The risk factor will be dehydration, hypoxia, having infection. The infection actually doesn't matter what infection is. Having fever or a fever, being in high altitude, a sickle cell crisis can turn into organ failure. And the two organs that most likely will fail first will be the liver and or the lungs. The patient could experience an acute vaso-occlusive crisis, and this is when the blood, because of the misshapen blood, would accumulate in certain areas, especially the liver and the lungs, causing the person to have inflammation and hypoxia. So the person could have acute vaso-occlusive crisis. This is when the blood accumulates and the person can suffer of inflammation, hypoxia, and most likely that would happen in the liver and lungs. All right. Because of that vaso-occlusive crisis, the person could have pulmonary hypertension that most likely initially is going to be asymptomatic, meaning no symptoms. But then later on the person may present with fatigue, dyspnea, dizziness, chest pain, and the person could end up having a stroke. We also, some of these patients may have low testosterone level, may suffer from infertility and erectile dysfunction.
And that's a cause.
because
That's
of the
cause
shape
effects.
of the blood.
Okay.
Pulmonary, was it?
Pulmonary hypertension. The next issue that these patients are gonna have, okay, I know I'm giving you a lot of information on thalassemia. When we get to treatment, you'll make sense. Thalassemia and treatment, a lot of stuff are gonna make sense. Okay, so the next thing, the person could have acute chest syndrome. This is when the person develops fever, cough, wheezing, the person could die.
Is this still sickle cell?
Yeah. Remember, there is a question after each disorder, so.
Okay, well,
What are the symptoms of acute chest syndrome?
Fever, cough, wheezing, the person could die. So think about chest syndrome. What would be the diagnosis for that? How do we diagnose? Chest X-ray. How do we treat it? So the person have fever, cough, have some wheezing.
Steroids?
Albuterol.
I'm gonna say it again. Fever, cough, wheezing. And you could be right with albuterol. However, this is the only time that we're gonna go for antibiotics. Believe it or not. But in any other disorder, you will immediately albuterol. That's it. Could we give albuterol? Of course.
This is due to sickle cell.
Because of the shape of the blood cells.
So we're
They're gonna get stuck, right?
Oh, so we're gonna give it
Hmm?
You said we're gonna
Antibiotic. Most likely the person has an infection because of the coughing and the fever.
also like you open well because they're already at a higher. And is this to do with still risks or just like selling you guys?
Well, we used to give an antibiotic to people that have sickle cell anemia all the time. We don't do that anymore, right? Because what happens if you give somebody an antibiotic all the time? Resistance. So we don't do that anymore. So it's only when most patients that have sickle cell, they know immediately something is wrong, right? Because it's going to be right here. Remember what I tell you? The organ that is going to affect the most is going to be the liver and the lungs. They're going to know right away. So they immediately will call their provider.
So the acute, the acute has
Yes, correct. I've only taken care of 2 patients with sickle cell anemia, and they both needed transfusions, like on a monthly basis. It was really, and they were not from here, they were from somewhere in the Middle East, and they were here at Mass General for over 2 years. And then they got discharged, and because it wasn't cost effective. So they got discharged and they rented a hotel room, and that's where people were going to give them the blood transfusions. That was their home where they were getting. So,
So just to confirm, they're only giving antibiotics if their inflammatory markers are high or.
well, as soon as the patient presents with fever, cough, and wheezing, and we know the person has thalassemia, we're gonna give them antibiotics. Because most likely they have an injection, an infection. And we don't even have to test them to see what the infection is. We just give it. I did? I'm sorry, I apologize. Yes, you were All right, what's next? All right. Okay, one more thing, the treatment. So, one of the medications, you already know it, folic acid. Okay? We give patients that have sickle cell, we give them folic acid to help increase the production of red blood cells. Folic acid to help increase the production of folic acid. Pain. If it's mild, most likely we're going to give the person acetaminophen. We can even give aspirin. But other medications that we can give to the person, gabapentin usually works beautifully for somebody that has sickle cell. Okay? But the medication, once again, if it's for pain, it has to be something that is appropriate for the person, right? So that means that the person is going to have multiple prescriptions for pain medication, right? If it's between 1 to 3, acetaminophen, aspirin. If it's 4 to whatever, maybe a gabapentin. And if it's, let's say, 7 to 10, maybe something else. But gabapentin seems to work quite well for the sickle cell. Patient may need red blood cell transfusions. If these patients, dehydration can cause a crisis, it will be very important to educate the patient about the proper fluid intake. There are 2 more medications. So folic acid, we agree that it helps with increase the production of red blood cells. So is jolupatercept. I don't even know how to pronounce that. But it also helps increase the production of red blood cells. And then a very, very important medication, when I was in nursing school, that was actually the #1 medication that we used to use when patients have sickle cell. Hydro. When the person is having a sickle cell crisis, is the best medication that the patient who has sickle cell can take. It actually lowers the episode. And if it lowers the episode, it helps alleviate pain. However, that medication is teratogenic, meaning that if somebody is pregnant, that person should not be taking that medication.
You
Very,
said
very important.
it lowers the episode?
Cause of cancer.
No, but you said it lowers the episode, so it like brings down the crisis, it just helps with the crisis?
It alleviates the
Okay,
crisis.
okay.
It reduces pain.
Because it causes cancer?
So the medication wasn't developed to reduce pain, right? It's because it's helping with whatever is going on with the crisis. In turn, that's going to lower the
So
pain.
it's not taken all the time?
No, it's not taken all the time. They used to, not anymore. Could we have some patients that are taking it all the time? Of course. That's why, what did I tell you? Last semester, the first day during orientation, do not answer the question based on a family member or a friend. All right, here we go. Pregnant female. That's the question. I'm not asking if someone's pregnant. Just want to show. All right, let's eliminate something. Well, A, what do you think?
No.
All right. B, should we keep it?
Yes.
C.
No.
So remember, the whole time, even before the person gets pregnant, right? And then how do Could you give a transfusion during pregnancy?
No. Unless
So my question was, could you give a blood transfusion during pregnancy? Yeah, you want to let that person die? By the way, that was my first question in the NCLEX. And I went crazy because I didn't like maternity, so I almost flipped the table. I'm like, what the hell is happening for this? So I finally calmed down, right? Oh, it needs fluid. Good. It was probably the only time in my life doing a test that I was stressed. Because when I take a test, I was stressed. I didn't know what to do. And I was by the window and I was like, what is it? What is it? Oh. Fluid increase. It needs fluid. Boom. Let's go. All right. What do you think? So once again, after here, I'll go to my office. I will upload the PowerPoint, and by tomorrow, I will send you some of the questions without answers. The questions are related to the material and the exam. All right? You good? We're going to the next one. Ooh, the thalassemia. What time is it? Will I take it? Do you want a 10-minute break? That was okay, thalassemia, let's go. So patients are going to have, what's the word? Oh, I should have started with that. So it's a genetic disorder. You get it from your parent, or whoever has it from their parent. The person is going to have a decrease in red blood cells. Once again, if the red blood cells are less, the person is going to have less oxygen. So based on that, there are some tests that we need. We need the CBC with differential. We need the H&H. For thalassemia, we also need an EKG or ECG. Platelet count. We use a mapping, gene mapping, to find out what genetic disorder the person has. Okay? And then the main test will be, so usually the genetic disorder found beneath their parents, or the person was never tested, and the person, parents, sometimes don't have any symptoms, maybe the child has some symptoms, so they will have to look into that. But the main test for thalassemia is your hemoglobin E. It's right here.
It's different than a lab though, or it's part of the labs.
I'm sorry.
It's a lab, it's a.
Yeah, it's a lab, yes, it's a lab. But that's the main test for thalassemia.
So is that like a hemoglobin production test?
Yeah.
That's like a
So, who is at risk? Major risk, family history. So, depending on which thalassemia it is, it's not always African descent or Mediterranean descent. It could be Italian, so it all depends.
So does this
Once again, the
present
NCLEX don't ask you about those details. You don't have to know that. Okay? But, by the way, also Chinese population can get thalassemia, the minor ones. Yes. Yeah.
So does this often present like at birth or for everybody?
So the person will have, right? Because the mutation in the gene.
Yeah, but I'm just
has to
like
be-
the.
But signs and symptoms, usually when the child is born now. Unless it was a hard delivery where it was very difficult and maybe the head was pressed and stuff like that, then the child will have that.
And I think the pigment is into, like, the pigment changes, because my brother had a pigment, and we didn't know what it was, and when we tested him, he had a thalassemia. But, he was just, he had it when he wasn't, anybody that is gonna get married had to be tested
Yeah.
before it can be done.
Correct. Absolutely. So, where are we? All right. Let's move to the next one. The question on, thank you, the question on the exam is gonna be more on treatment for this particular topic. Okay? So thalassemia, you don't have to know how, if both parents need to have it, yes, you will need to know that, but you don't need to know which particular gene because there is a whole bunch. Okay? So what you need to know is that thalassemia is caused by a mutation on that particular gene, whether it is beta thalassemia, minor, major. By the way, there are 8 different thalassemias. Yes? So, if the thalassemia is minor, most patients don't require any treatment.
If it's minor,
Yeah. Whether it's alpha minor or beta minor, most likely the person is not going to need any treatment related to the thalassemia, right? Yeah, go ahead. Go ahead. Okay. So the prognosis for the patient depend on the type of thalassemia. Obviously, as we discussed a minute ago, if it's minor, that means the person is going to have a long life that has nothing to do with thalassemia. Can the person pass it to their children? Yes. If it's major thalassemia, the person can have heart failure, liver and spleen issues or failure. I also only have taken care of 2 patients that have thalassemia, only 2. They were also brothers, so these 2 were identical twins. The one that had pickle, they were brothers, but they were not twins. There are 2 patients that I took care of that were have thalassemia, they were identical twins. And they needed also lots of blood transfusions. Minor, most likely no intervention.
Jose?
So would
Yeah.
they treat the symptoms? Sorry,
I am beta thalassemia minor,
Okay.
and it did affect me earlier when I was much younger. I would have like syncope and everybody said I was anemic, but
Well, having thalassemia, you're anemic.
yes, but they were just like, you're anemic and they keep giving me iron and
Yeah.
all of that. Didn't work. When I was in my 30s and I lived here, my primary care physician looked at my blood work one day and said, "Are you sickle?" And I'm like, "No." And he's like, "I don't like the way you're presenting, so I'm gonna send you for a study." So they did a study at Hematologic Center at Cape Cod. And that's when I discovered that I was thalassemia minor. I'm fine, my blood won't go above a certain level.
The should never have given you any iron supplement.
That's right, and like the hematologist said, you don't need to take iron because it's not gonna affect you. So,
But you were asymptomatic because you were already an adult.
yes, and it was affecting me in my early 20s though. I used to pass out, I had to have company anywhere I go, and because Jamaica is hot, so once the time gets hot and you're sweating, you sync up episode, but now I'm fine, my blood group seems normal and to the most normal that it can be.
Good. Very good. You have a question?
no, well, I'm just saying, like, with the minor, like, I know you don't need treatment, but like, do you treat the symptoms, like with enlarged spleen, things like that? Like, are they just take precautions?
If that's what the problem is, yeah.
Okay,
Yeah.
all right.
But I say most likely would not need treatment, but there's a subset of the population that may need it. So I didn't say every single person that might. Okay? All right. Now, how is it treated? Do we know?
Blood transfusion for
The blood transfusion is the most important. Because some of these patients most likely is going to have a little bit too much extra iron in their body. There is a medication there. Well, I didn't write it. No, I didn't put it on the list. I just remember I actually did.
You
So,
said they have extra iron in their blood?
yeah.
Okay.
And that's why you should never give patients with thalassemia a supplement, iron supplement. Yeah, and they can have an overload. That can actually create, or persons that are having cardiovascular problems. Chelatin, CHELATIN, is used to reduce complications when the person has too much iron in their body. We can give that medication and usually help remove some of the iron out of the person's body.
What was it called?
CHELATIN.
Is that gonna give the same effects of like giving someone iron, like they're too darker and
No. So when you give somebody iron, you put it into the body. Now we're removing it.
Yeah, I just.
So no. All right, what's next? Oh, question. Okay, which A? Will we leave it or will we remove it? We're gonna keep A? Or we're gonna remove it? Okay, how about B? So, keep it or remove it, B? Huh? Remove it, okay. How about C? We're gonna keep C, and how about D? All right? All right, next topic. Lord. All right. G6PD, very important. It's another genetic disorder. But there are risk factors, so that includes being of African, Asian, or Middle Eastern descent. So that means that it runs in families, so there must be somebody in that family that has a history of G6PD deficiency. Other risk factors including having hepatitis B or C. If the child is born with jaundice, we also immediately test the child, should be tested for G6PD. There are some medications that actually are a very high risk. That includes a number of different antibiotics. It's like 50 of them. So we're not going to go through those. Somebody that is taking acetaminophen also puts that person at risk. Taking vitamin K. And somebody that eats a lot of fava beans. Symptoms: tachycardia, SOB, jaundice. Oftentimes the patient has either blood in their urine or the urine is dark. Normal GCPD in the body is 7 to 10. Labs. Well, we know in order to diagnose it, we need G6PD test, a blood test. That would be to diagnose it. We also need a CBC, and bilirubin will have an increase. How do we treat it? Very simple. Avoid all those meds and substances that have an exacerbation. So those antibiotics, acetaminophen, vitamin B10, valvoline, and both parents have to be tested, the child has to be tested. Okay? So there's a question there. Okay, A, you like it or remove it? B. We're gonna keep B, okay. How about C? We're gonna leave it or remove it? Okay, how about D? You notice how the last three that we just discussed, we're gonna do transfusions? You notice that, right? Okay.
You said this one also needs confusion?
So why wouldn't D?
Because we already will have an order. Okay? That's the only difference. And it's not going to be a possible transfusion, it's going to be a transfusion. Okay? I want you to remember that the last three disorders that we just talked about, transfusion.
Can you repeat those three? Sickle cell?
Sickle cell, thalassemia, and G6. I always want to say close together. Okay, the next disorder, which probably will be the last one that we can cover. Oh no, we might cover two more. Okay, what is this? Where are we? Plastic anemia. Okay, good. So, this disorder is caused by a decrease or damage to the bone marrow. And what is happening in the body is the cells that are supposed to be produced in the bone marrow are being replaced by fatty tissue. And this is a result of tumors, pregnancy, insecticide, and some meds, including antibiotics. And there is only one antibiotic that I need you to know. There is over 25, but it's only one. Tetracycline. Also, could be caused by patients that are taking immunosuppressants, like after an implant. So I'm talking about lung implant, and for patients that are also taking testosterone. Your assessment is going to be to find out whether or not this person has frequent bacterial and or fungal infection, how do we diagnose aplastic anemia? So is there a problem with the bone marrow? What are we going to do? Bone marrow aspiration, right? And we also need a CBC. Why? Person can have other issues. How do we treat it? For disorder that we talked about in the road that patient needs or may need a transfusion. How do we remove the cause? If the person is prescribed tetracycline, as a nurse, what are you going to do? Advocate for that person so that the person will not have that medication. And then the person can have a bone marrow transplant. Person could be given short-term corticosteroids. These are the number 1 and 2 as a corticosteroid prescribed. Prednisone is the number 1. Short-term, about 4 days, 7 days. If somebody put on prednisone for 4 days, that person does not need to be. The medication does not. 4 days or less, there's no regulation. However, most providers still do it. I don't know why, but you don't need it for only 4 days. Prednisone or corticosteroid helps increase red blood cells. And it does it within 24 hours. Okay? Got it? Can I move to the question? Yes. So if we want a priority, what do you think about it? Leave it or remove it?
Yes.
So I said, I'm assuming yes means stay. Stay with that. B. So remember, nutrition is going to help, but how about physical therapy? That's going to help, but right now, that's not a priority. And what about D? Good. So we can go over the next disorder and then that's it. Okay. Now, what's the normal platelet count? Not in there. I hope not. No, I didn't put it. 150,000 to 450. 150,000 to 450,000. So, for somebody to have thrombocytopenia, they need to, their platelet needs to be less than 101. Okay? So what would that mean for the person? This is a decrease in platelet count that could be caused by leukemia, having a bone marrow dysfunction, having a plastic anemia that we just discussed, by having infections such as TB, Hep C, chronic alcohol use, chemo, radiation, how do we diagnose it? By doing a bone marrow aspiration, and then you also need to test the person for Hep C. Sequestration in the spleen of red blood cells mean that they're stuck in the spleen, they're not going anywhere. So that's a problem. How are we going to treat it? If there is bleeding, we're going to stop it. Person needs transfusion of what? Platelets. Good. And then, if there is an underlying cause, we're going to treat that. Right? You're going to treat the hepatitis. If it's chemo and or radiation, what we could do is reduce the dosage of that chemo and or that radiation. Right? Okay. Good. And this is short and sweet. But I'm going to tell you next. Primary thrombocytopenia. Patients have a blood count less than 30,000. Symptoms that the person is going to have is going to be bruising, heavy menses. 30,000. 30,000. Labs. Hep C, HIV, bone marrow, platelet count. How are we gonna treat it? We still, I can do it in the next slide, it's still the same subject. We're gonna treat it with blood transfusion, but the main medication is going to be corticosteroid, prednisone, short term. And as I told you earlier, it should start increasing the red blood cells within 24 hours. For some patients, they may have to remove the person's spleen in order to fix the issue. Because then that's going to result in an increase of platelets. With your question? Okay, what do you think about answer A?
Yeah.
Yeah.
Oh, yes, you want to.
Okay, B.
No.
Okay, we're B. C. And D?
No.
Got some? We're gonna go one more, that's it. Because I still have a few minutes, and this is short and sweet. Okay. Did I jump one?
Yes.
Did I? Okay. Next one. Can be caused by dehydration. Could be somebody that is taking anabolic steroids. Are anabolic steroids man-made?
No.
So dehydration by taking also anabolic steroids like testosterone, by having COPD, smokers, so smoking, by having kidney disease, and believe it or not, by somebody having prolonged stress. Like when you're in nursing school.
And now we're all gonna diagnose ourselves.
How do we treat it? If there is bleeding, we're gonna stop the bleeding, but most likely it's gonna be none. Stop smoking. But the main reason or the main treatment will be phlebotomy, meaning to remove blood from the person. Because that will reduce the viscosity and the volume of blood in the body, and that will actually reduce symptoms. Because if the person has polycythemia, the person can have also cardiovascular problems that can cause stroke or a blood clot, or multiple blood clots. So we're going to stop smoking. Most likely the person needs phlebotomy to reduce viscosity and volume of the blood, and that will take care of the symptoms. We don't want the patient to develop any cardiovascular problems. And I believe this is the question. Okay. So, answer A, what are we going to do? Huh? Remove it? Okay, B.
Yes.
Guess what? Keep it. C.
No. Something.
We're going to leave it okay at D?
Yeah.
All right, so we'll continue on week from today.